if the patient has a syncope. If the patient has a syncope, it's very important to know um, how it was exactly. I mean, if the patient knows if before the syncope, if he has a prodrome or not, if he has some signs before syncope happens or not, because you can judge if it's a arrhythmia syncope or it's a neurologic one or something like that. And after that, you have to ask if the patient knows how much time it lasts. Usually, it's easier if somebody else from the entourage is around because sometimes the patient doesn't know because lose the time notion. And after the syncope, if the patient is clear-minded immediately, or is dizzy, or is I don't know, slow or something like that, that means you have to let the patient to say, and after that you will ask specific question about the physical exam. Physical exam, has four parts. That means observation. Observation, it happens from the beginning, from the door of the room. You just see if the patient is young or old, if the patient is in distress or is calm, if there is a very clear thing uh, about the patient, if it's cyanotic, if it's dyspnoic or something like that, is pale, you see immediately. But you continue observation during clinical exam all the time. Palpation. Palpation is not that important in cardiology. Yes, palpation it is, sorry. Percussion is not that important. Palpation is because sometimes you have to define where's the apex beating, and I don't know the word, I forgot. And if the heart is big or not, if there is some thrill which accompany the murmurs, you this can see on your palm. Uh, um, I don't know, palpating the patient. And finally, the main part of the clinical exam in a cardiac patient is auscultation. This usually is done with the stethoscope. You know this? Okay, I'll go to the back to the, okay, sorry, okay. You can see the next one? No, you cannot
No, no.
because mm, okay, I'll do something different. I'll, I'll okay, good. You know, clinical exam, it was much more important in the past because there not they were not good examination investigation, and for this reason everything has to be extracted for the clinical exam. Now it's not that rigorous, and it's less important. For instance, to examine from the right part of the right side of the patient was something extremely important. And actually, this kind of very important thing, it was kept in clinical examination in almost nowadays, and still there are some person which insist very much about this and give penalty if you don't examine on the right side, but it's not that important actually. Still, I advise you to examine from the right side. You have better position for feeling the liver and for examining the patient actually. You see or not? The next slide, heart failures.
We
Yeah,
Yep, yep.
good because okay. Uh, About heart failure signs, usually you know very soon when a patient is with heart failure, because usually has dyspnea and has edema, but sometimes edema is not that obvious. But there are still systemic stasis, and systemic stasis is not only leg edema, but it's jugular uh, how to say jugular vein engorgement, and you can see jugular vein like in this view, and actually you can calculate the venous pressure immediately. You can calculate the venous pressure from this image. You see my pointer.
Yes.
Yep.
You see it?
Okay, just you see where the Stener angle is. We call it in Romanian Luis angle, if you remember from anatomy. And from this point till the point of the engorgement of the maximum point of the engorgement of the jugular veins, you just measure the distance, and this is the venous pressure in centimeters water. And usually it's normally it's about 10 to 12. If it's more than that, means that is systemic stasis. If it's less than that, maybe it's the head of the patient. Okay, let's go. Okay, about leg edema, you know very well, probably it's simple, but usually in heart disease, in cardiac disease, leg edema is a little bit cyanotic in it's heavy and it's painful, like in this patient, but this is an old patient. So it is a pitted edema. I mean, if you press with your finger, you have a small, not hole, how to say, depression, which lasts for a while. Like in this case, sometimes there is only a unilateral edema, like in this case. In this case, it's most probably to don't be a cardiac problem, but mostly a local problem. Most probably deep vein thrombosis on the left leg, because this is normal. This is it is swollen. And in the final stage of heart failure, the patient has this discordant appearance. It's weak, and, and the body which is not involved in edema, but it's very thick in the legs where edema is, and sometimes in the belly because ascites. Mitral mitral fascias, it's actually uh, pulmonary hypertension fascias. It's not mitral actually, but because the mitral stenosis was the most frequent kind of frequent cause of pulmonary hypertension, it is called mitral fascias. And you see how it means. It's a pale face except the molar, the nose, and the lips. But the rest of the face is pale. You can see even in black people, you can see this cyanosis. Hypercholesterolemia, you help in your diagnosis of atherosclerotic diseases by looking for ancillary signs which are associated with hypercholesterolemia. And these are the most frequent, these deposits of cholesterol, arterial deposit of cholesterol. In infectious endocarditis, there are some signs of peripheral emboli. And you see here in finger, nails, on palms, all of them can show that an embolus was right there, reached that vessel. About clubbing, these usually are in congenital heart disease, cyanotic congenital heart disease. You can see here how it is, and I hope you'll see some patients during your stage, because it's much more relevant to see a patient than to see a picture. This is a scheme of the arterial circulation, because on the clinical exam, you have to palpate the arteries, and usually the arteries which are palpated in most of the cases are radial, sometimes ulnar as well. Brachial, which is palpated here, a little bit higher than the elbow, and the lower limb, like femoral here, popliteal on the dorsal part of the knee, and here two arteries. This is posterior tibial artery, which you can palpate superior and inferior of the interior malleole, and dorsalis pedis, or pedial artery, which is palpate on the dorsal part of the foot. About the auscultation, you have to know where's the apex beat, and usually it's in the 5 intercostal space. And you see in this drawing, in this picture actually, the intercostal spaces, and here is the apex beat. You can feel it, sorry, with your finger. For the murmurs, for the thrill, you use the palm. For the apex beat, you use the fingers. Okay, the stethoscope will help for auscultation. This is the link, but I send you all on your email for listening the heart sounds. And these are the auscultation cardiac area. You see the mitral area, the tricuspid area, aortic area, pulmonic area. These are the second intercostal space. These are in the 5th intercostal space. And you see there are some radiation. For aortic stenosis, the usual radiation is towards the lateral cervical area, because the murmur is going the ascending aorta and the branches in the carotid arteries. For aortic regurgitation, usually it's radiated in the 4 or 5 intercostal space. Do you know how we call this area? It's a special name. This point.
Arbs.
Exactly. Very good. Good. For pulmonary regurgitation, you see here, and for mitral regurgitation, usually you go in the axilla. Mitral stenosis is not radiated at all. As well, pulmonary stenosis is not radiating. Sometimes you have to do some special things for auscultation to improve, to augment these murmurs or sounds. For instance, in aortic regurgitation, all the diastolic murmurs are here worse. You cannot hear that easy that like systolic murmurs. For this reason, you have to be very attentive, and you have to do some special maneuvers. For instance, in aortic regurgitation, it's better to put the patient to sit and to listen after exhaling. I mean, it's a post-expiratory apnea, and you will listen better the murmur. The same position is valid for pericardial friction rub. For mitral stenosis, do you know which position is recommended to augment the intensity of the murmur for mitral stenosis?
Left lateral decubitus.
Exactly, exactly. That means if you don't hear well, you have to do this maneuver. If you hear perfectly, you don't have to do anything. But if you don't hear well, you do like this. The heart is closer to the thoracic wall, and you'll hear better. Okay. For measurement of blood pressure, you know, it's very easy. The device, probably you know already. You can measure the blood pressure for the lower limb as well. Usually, you put this cuff in the how we call it the lower part of the leg. Remember, cuff. Ah, okay. You put your cuff in the cuff of the patient, but you just palpate, and you can measure only systolic pressure, not diastolic pressure in that case, if it's by palpation. Okay, that's about blood pressure. But I want you to tell few things because you have lectures about ischemic heart disease, to discuss a little bit about chest pain. Chest pain is the most frequent symptom from which the patient is coming to the emergency room, and is the most frequent cause for swing doctors. I mean, it's important to deal well with chest pain, and actually, because there are some problems with diagnosis chest pain, some countries or hospital have special departments for chest pain. But speaking about chest pain, even though it's an important cardiac symptom, most of the chest pains for which the patient is coming in the emergency room are not cardiac. You see, 1/4 till 1/2 of the whole chest pains are because of the problem of the chest wall. You see this list. Can be cardiovascular disease, but not necessarily coronary heart disease. I mean, you can have chest pain in aortic stenosis or in aortic regurgitation as well. You can have chest pain in some cardiomyopathy, usually in hypertrophic cardiomyopathy, in pericarditis, or aortic aneurysm. You can have some list of cardiovascular diseases, not only in coronary heart disease. But speaking about coronary heart disease, you see acute coronary syndrome. That means the most urgent kind of coronary heart disease. It's 1.5 to 3.6% of all cases of chest pain. That means they are not much. This you have to admit and to treat in specific way, in emergency way. Okay, you see respiratory disease or psychogenic etiologies like anxiety, gastrointestinal or esophageal disorders, and from all non-cardiac chest pain, you see A lot of them are gastrointestinal, musculoskeletal, that is chest pain, psychiatric. And for a more detailed list of the diseases, you can see here from uh, gastroesophageal reflux disease or esophageal problem. You see here all these list of diseases. For diagnosis of the chest pain, you have to take in consideration a few things. One of the most important, and I want to discuss with you, is pain assessment. Tell me, who can tell me about how is the chest pain, of coronary chest pain? How is the pain? Describe a little bit. Who knows? I mean, you have to know some characteristic of chest pain and some problem, some circumstances of appearance and disappearance. About characteristics of chest pain. Tell me, it's usually the coronary chest pain appear in the small area or a large area?
In a larger area, like a claw, for instance.
Like a cloth.
Claw, ghiara.
What is cloth? It doesn't mean the area, the cloth. Mean the character of pain, but not the area of pain. Okay. Yes.
It can radiate to like the shoulder and the jaw, stuff like that.
Okay.
So that's why it'd be
Okay.
large.
No. This is separate. Let's say like that. One, usually it's larger area, and usually the patient show the pain with the palm like that, or with the fist. If the patient show with the finger, means it's a small area and it's improbably to be a coronary heart disease. Usually it's a skeletic one. Yes, that's the area. The second one is the radiation. You told me about the radiation, sometimes radiates. And can you tell me exactly in which is the most characteristic? I mean, few sites of radiation. You mentioned jaws or left shoulder, something else?
Arm?
Arm, yes, or arms. Usually it's
Arms.
but yes, but when it's the most more severe, it can irradiate in both arms. Okay.
The
If
back also.
back, yes, can be. It's not very frequent, but it's characteristic as well. If radiates on the upper limb, not only arm but forearm as well, usually it radiates on radial or ulnar part of the hand.
Ulnar, on the little
Ulnar,
pinky.
perfectly, exactly. Never on radial, usually in ulnar all the time. Okay, very good. But the type, the character of the pain, you mentioned claw. What means claw? I understand ghiara, but what kind of pain is claw?
It's a squeezing pain.
It's a squeezing pain, yes. Even though when somebody told me in Romanian, ghiara, I don't understand that, because it's like, I don't know, something sharp, a claw. But okay, it's a squeezing pain, but it's not only type of pain which appear in coronary heart disease. Tell me some other characteristics type of pain, except the squeezing. Can be a pressure, that means like a stone on the chest, or can be some burning, pain. These are the more characteristic type of chest pain. If it's like a stabbing, pain is not characteristic one, and usually it's not a chest pain. Tell me about chest pain. If it's intense or not intense. In coronary heart disease, I mean.
It's intense.
Usually it's intense, but it's not a rule. Usually it's intense, but sometimes it's vague. It's still important, and the pattern of rising and decreasing intensity is like that. It's a progressive rising of intensity. After that, it's a plateau, and finally, after few minutes, is decreasing progressively. This is the coronary chest pain. For instance, in the aortic dissection, which is another type of chest pain, cardiovascular chest pain, the intensity of the chest pain is maximal from the beginning. It's not a progressive rising, but it's very strong, very intense from the beginning, and actually the patient, a lot of patients have syncope because of this pain. But this is aortic dissection. We speak now about coronary heart disease. Okay, the characteristics of chest pain are important, but it's not perfect. I mean, even with a typical chest pain, you can have other explanation of the chest pain, not only coronary. It's important to know the duration of chest pain. How is the usual duration of chest pain? I listen.
Longer than an angina.
We are talking about angina.
1 to 5 minutes, but no
Yes.
more than 20, for instance, in stable.
Exactly. You told me from the book already. It's perfect. It's like that. It's 1 to 5 minutes. If our more severe episodes can be 10 minutes, 15 minutes, but usually not more than 20. Less than 1 minute is unusual, but it's not impossible, because every person has his or her personal threshold of pain, and some person can feel pain very intense. Some person can have no pain during myocardial ischemia. Okay, but the most important thing in coronary chest disease are the circumstances of appearances and disappearances, and these are very classical. But still, tell me, when appear usually the coronary chest pain? Angina, let's say.
At effort, stress, after we eat a lot,
Exactly.
and also cold, if I
Cold
missed that. Yeah.
or emotions, positive or negative emotions, yes. And when is disappearing the chest pain? What are the circumstances?
Resting.
Usually resting, exactly. Or if the patient has drug treatment, a very rapid drug treatment, which is called
Nitroglycerin.
sublingually. Yes? Why sublingually?
We shunt the hepatic circulation.
Exactly. Exactly. And act more rapidly. Very good. Okay. That's about pain assessment. Usually, the coronary heart chest pain is not different with inspiration or expiration. It's constant. But other causes of chest pain can be different when a person inspire and intensify, or in position changes, or on pressing of the chest, the patient can reproduce the pain. That means this kind of important for judgment. But what you see more? Okay, we've finished already with pain assessment. about symptoms, if the patient has other symptoms which is correlated, is associated with some kind of other disease, you see like pulmonary or gastrointestinal, musculoskeletal or psychiatry. It's important as well the past medical history and the family history, because coronary heart disease can be not hereditary, but it's increased probability if your parents has this disease. And the risk factor assessment. The other part of the clinical examination is a physical examination, and just you try to know if there are some hints that the chest pain is cardiac or no. I will go to the immediately try to. Okay. These are few things that we have to that orientate you how to diagnose origin of the chest pain. One about characteristics of chest pain, we'll already discuss about this. The other one, age and gender. Okay, usually chest pain is more frequent in older persons, and it's more frequent in male gender than female, but it's not all, because sometimes in female patients the symptoms are a little bit different. Sometimes can be very severe, very intense, and still not representing coronary chest pain, but anxiety something or some other things. It's less let's say proportional with the risk, the intensity of the chest pain in female patients. You have to be more cautious. Otherwise, they can have coronary heart disease as well. Past medical history is important, because if the patient has already myocardial infarction or some other problems, heart problems, it's more probable to be a coronary chest pain. Risk factors. There are some specific risk factors which was shown that are correlated with the probability of atherosclerotic coronary disease, and these you know already probably are diabetes mellitus and hypertension and hypercholesterolemia and obesity. Okay, something like that. And if the patient has this, that even other risk factors which you have to take in account. For instance, renal failure. A patient with renal failure is more prone to have coronary heart disease, coronary problems, and valvular as well. But we discuss about coronary. Or the patient with say with rheumatic diseases, it's more frequent with coronary heart disease as well. And it's after that it comes about clinical examination. I told you how to do a clinical examination, but you have to do it at the bedside. But what you look for to confirm that the patient has coronary heart disease, you look for signs of hypercholesterolemia, and after that you look for other territory which are affected by atherosclerosis, like diminished pulses or murmurs in carotid arteries, renal arteries, and diminished pulses usually in lower limb vessels. For this reason, you have to palpate in most of the cases, maybe all of the cases, the peripheral arteries to know if there is an involvement of those. Okay, or you can find them clinical exam some other things which explain the chest pain, like I don't know, pneumothorax, like or pericarditis or pleural effusion, something like that, which can explain the chest pain. And finally, we consider that the ECG is part of the clinical exam, actually. And the ECG can show some signs for diagnosis chest pain. If it's an acute chest pain, that means the patient can have myocardial infarction or unstable angina. Usually ECG will show very quickly. If we're talking about chronic coronary heart disease, 50% of the patient has no ECG changes on the rest ECG. Only during chest pain or during exercise or something, they can have ECG changes. If you don't clarify things with all these, you have the investigation, which some of them, if maybe almost everything of them can be done at the emergency room. For instance, troponin, which is increased in myocardial necrosis, chest X-ray, which is non-characteristic for coronary heart disease, but can show some other causes of coronary heart chest pain, like pneumothorax or aortic aneurysm or dissecting aneurysm or effusion, pleural effusion, or so on. Echocardiography is very important, not for diagnosis directly coronary heart disease or chest pain, but showing if there are some problems with the heart and show some previous MIs or some specific other cardiac disease which can explain the chest pain. And nowadays, in the last 5-10 days, in some hospital, they done CT and with contrast CT at the emergency room to see, one, if there are some coronary problem. You can see by coronary angiography with CT, or if there are other problems which are frequent explain chest pain, like aortic dissection, which is not that frequent, or pulmonary embolism, which is more frequent indeed and can be diagnosed by this method. This is the election investigation for pulmonary embolism. Or finally, you can send quickly the patient to the coronary angiography, which not only diagnoses the blockage in the coronary arteries, but can cure and treat it directly this. Okay, that I prepare for clinical exam. I want from you to tell me what is not clear for the lectures for the subject of coronary heart disease. You have already 2 lectures about it: stable coronary disease and unstable angina. Do you have questions? Nothing? Everything is very nice? You know, you have to know, because you have to diagnose your patient, and it's important to know. Okay, I will tell you a few things. Usually, coronary atherosclerosis is evolving in years. It's starting at a younger age, actually, at post-mortem examination of the soldiers, which American soldiers from Korea, that means patients of persons of 20, 30 years, a lot of them has had atherosclerotic in coronary heart disease. That means the process starts from younger age, and it's going slowly. Usually, it's I don't know. There are two factors which are important. One is the hypercholesterolemia, and the second one, the degree inflammation, and can evolve very slowly, but suddenly to become unstable. The plaque and the unstable plaque can give progression to the occlusion of the vessel, or just if it's not that important, to increase suddenly the atherosclerotic plaque. That's the evolution from the smaller atherosclerotic plaque to complicated one, which is responsible for the unstable angina and myocardial infarction. Speaking about angina pectoris, I want to ask you if you know how a stable form of angina pectoris can become unstable form. Which are the factors which can destabilize this disease? Do you know? I want you to know to tell me some factors.
Increasing stenosis.
Increased stenosis. Usually, it's not the main determinant of instability, but in time can be, but it's not in the important factors.
Increasing oxygen need of the heart.
Requirements. Yes, can be, but give me some example of increasing needs of oxygen.
Hypertrophy, for instance, of the heart.
Yes, because the contractility is more muscle and the contractility is stronger. Yes, but
Hypertension.
Hypertension, the same. It's like hypertrophy because hypertension determine hypertrophy, and each beat has to be stronger and the oxygen need is bigger. Okay.
It's just stable angina becomes unstable when the intraluminal plaque has built up, right? In the coronary arteries.
Yes. Yes. Mihna told me about this, but I want to give me more examples of factors which destabilize stable angina. Try. Except hypertrophy, in which circumstances the cardiac need of oxygen is increasing.
Increased heart rate.
Increased heart rate, indeed. Increased heart rate by sinus tachycardia or some arrhythmias, yes, tachyarrhythmias. The most frequent is atrial fibrillation, which usually has increased heart rate. Okay. I want to hear some other from you. Only Mina ask me, answer me, and Joachim. But I want more from you. Which one can give me a hint? Okay, we have a patient. Let's have a case. Yes, we have a patient with known stable coronary heart disease, known stable angina, which evolved for the last 5 years. The patient is hypertensive but is on treatment. The patient is hypercholesterolemic but is on treatment. And suddenly this pattern of chest pain during exercise or what you tell me, emotion, everything changes. It aggravates. It became more severe and start to have pain even during rest. This means the stable form of angina became unstable. Except hypertrophy, which is a chronic actually process, and atrial fibrillation or other tachycardia, which is acute. I agree. What can happen? What we have to look for?
Bundle branch, maybe?
No, never. Okay. We look for some other explanation.
Coronary artery spasm.
Coronary artery spasm. Yes, can be. Can be, even though this is a different kind of disease. Usually, it is characterized to be a rest pain, chest pain during coronary spasm. But maybe the patient doesn't have this and suddenly starts to have it. Agree, can be a form, yes. What else? Give me an endocrine disease which increase the need of oxygen. Increases.
Hyperthyroidism.
Exactly. Hypothyroidism, which increase metabolism and made the patient tachycardic, and from these two mechanisms increase the need of oxygen. Okay. Or give me a hematological problem which give less oxygen to the heart, to the myocardium.
Anemia.
Anemia, yes. Sudden anemia, a patient who is bleeding, can be a cause of destabilizing stable coronary heart disease. Okay, these are the most frequent, but can be an embolus, which can be sent from vegetation, infectious endocarditis, or from an atrial fibrillation thrombus in the left atrium. There are few other uh, instances which can explain this destabilization. Okay, I can tell you another case. There is a patient which is 50 years old, and he had in the history acute rheumatic heart disease in his teenage period, but is perfectly compensate, no problem, till the last 6 months. In the last 6 months, the patient start to have some kind of dyspnea from intense efforts and chest pain. And the patient has a chest X-ray, and the heart is very enlarged on behalf of the left inferior arch. The patient is coming to you and tell you all of this, and you examine the patient, and you feel, you listen a diastolic murmur without thrill in let's say the fifth intercostal space, parasternal, and it's a descending diastolic murmur. Which disease do you think can be?
Mitral stenosis?
Mitral stenosis, yes,
Do-
no, it's not mitral stenosis, but still it's logical in a way because it's a usual consequence of rheumatic heart disease, yes, and has a diastolic murmur. But usually it's not this crescendo, and the patients with mitral stenosis are symptomatic earlier after the rheumatic heart disease episode, symptomatic by dyspnea. Some other suggestions proposed.
Aortic regurgitation.
Yes, actually, aortic regurgitation fits better for this description because the heart is in the left ventricle. That means the left inferior arch is increasing, which is characteristic for aortic regurgitation because of the volume overload, and has a very long period of no symptom after the episode of rheumatic heart fever, and has a diastolic murmur, which is this crescendo, and only in aortic regurgitation there is chest pain. In mitral stenosis there is no chest pain. Okay, the patient has 50. Which is the next exam? Okay, you do an ECG examination, a recording. What do you think is the most probably finding in ECG? The patient has aortic regurgitation.
Left ventricle hypertrophy.
Yes, it's a left ventricle hypertrophy, but it's a special kind of hypertrophy with less important repolarization changes, and usually with positive T wave. This is different from aortic stenosis, which has left ventricle hypertrophy as well, but has very important repolarization changes with deep negative T wave.
Is it eccentric? Is it eccentric versus concentric?
Exactly, or it's volume overload versus pressure overload. Yes, indeed, Joachim. Good. If you go, what you have to do with this patient? You just
Echo.
you diagnose the patient. The ECG supports your diagnosis, and Mihna proposed to do an echo. Echo is essential, and yes, this is the next examination that we have to do it. This examination is important because show how important is aortic regurgitation, and more than that, show how important is the modification of the heart because of the aortic regurgitation. Because of the heart, the valvular regurgitation are well tolerated, the patient tend to come too late, and because of this, there are some limits in left ventricular dimension, which determine to send to operation a patient, even though the patient can be asymptomatic, a patient with aortic regurgitation or a patient with mitral regurgitation. And for this one, for aortic regurgitation, means that the left ventricular systolic diameter has to be more than 55 millimeters, and this is enough for sending the patient to the surgery. Otherwise, the heart will enlarge more, and the operation will be less less successful, and the patient will remain with heart failure after intervention. For this reason, you have to check the left ventricle and the heart function after that to after examine and to decide if the patient needs intervention or not. But tell me, before this intervention, the patient has to be checked for coronary problems or not? Or we know that in aortic regurgitation can be chest pain without coronary problems, and we'll satisfied with this, we're happy with this. What do you think? Usually you have to check the coronary. There is a rule, then a patient, even asymptomatic for chest pain, has to be checked for coronary problem before an open heart surgery if the patient has more than 45. And this rule apply because the patient is 50 that we consider from the beginning. Okay, if we speak, and there is another thing which is important in echo examination, the ascending aorta dimensions. If is aortic regurgitation, sometimes it's related with ascending aorta dilation. And if the ascending aorta is too dilated, usually more than 50, the intervention has to treat this aneurysm as well. Otherwise, will be risk of aortic dissection after the operation. Okay, which operation is possible, or it's indicated if the patient has severe aortic regurgitation and the ventricle is dilated, as we established before?
Valve replacement?
Yes, valve replacement. In aortic regurgitation is not valid. We cannot apply the endovascular valve replacement. It's only open chest valve replacement. Only in aortic stenosis you can put the valve through the vessels, I mean, without open chest. In this, we have to do the classical intervention, yes, to change the valve, and if the ascending aorta is too much dilated, like we discussed before, to change the ascending aorta with a tube, with a synthetic tube, in which you implanted the coronary arteries. This is called Bentall intervention. You don't have to remember the name, but still, if we discuss about this, I can tell you that. Okay, good. Let's try another case. Or do you want to speak about ECG a little bit? You already have some discussion about ECG now. What you've done last week at the seminars?
ECG.
All the time?
A lot of it, yeah.
Pretty much, yeah.
And X-rays as well.
Okay. What do you want? It's for us. It's a first. I mean, we don't have much practice to discuss with you to do these practical seminars online. That means we are open to suggestions. I am open to suggestions. I will try to present you some cases. I will prepare some with slides, but I can imagine one on the spot. Or we can discuss more about a lecture that you have done before, or about this subject, what it was on previous lectures. or we can discuss about ECGs. What do you prefer? What is suited better for you?
I
Right.
think the cases would be good. I don't know how everybody else feels. Maybe
Yeah.
you guys say something.
Okay, I'll prepare some cases on paper or slides, but still, till that moment, let's discuss few cases, okay? Good, I will tell you about two cases that I present to the students which were on stage last week, or from the first group, not among you, because you are from the last half of the series. Okay, I presented two cases, very similar. A patient, a male patient of 70 years old, and a female patient, 66-year-old, which both have chest pain from, I don't know, a few months, maybe 1 year, both of them. Chest pain, which is rather stable. It's very classical, appeared of exercise or emotion as no chest pain during rest, or very similar. The ECG was normal in both cases, and no one has another arterial territory involvement in atherosclerotic process. One of them has the male has diabetes, new diagnosis, diabetes. Both of them have hypercholesterolemia in the same range, let's say, and hypertension, treated in both cases. In both of them underwent coronary angiography because everything was clear. The echo was normal in both of them. Everything was normal except the chest pain, which was important at exercise, not otherwise. And one of the male patient has bivascular coronary heart disease. That means from three territories that we consider the coronary territory, two of them were involved, right coronary artery and the circumflex artery. And the lady has almost normal coronary disease, or coronary arteries. I mean, has some non-obstructive plaques below 50%. That means it's not significant. What is the treatment that we recommend to those two patients? What about the male patient, which has epicardial coronary disease, and the female patient, which has no epicardial coronary disease? I wait for you. How we treat the patient? Which is the treatment for coronary heart disease? Do you know or not?
We have 3 steps. One is we need to tell them prevention and for instance, to assess the risk factors and reduce them. Then we have prevention for further disease, for instance, aspirin. And then we have the actual treatment with beta blockers, for instance, or calcium channels blockers.
Okay, you told me about medical and non-medical, non-medical therapy. That means life changes because it's prevented, and preventive measures like treating heart hypertension and hypercholesterolemia, they already did this. And after that, with aspirin to prevent an acute event, and with drugs which we call anti-anginal drugs to decrease the risk of appearance of chest pain during effort. Okay, like beta blockers, calcium blocker, you already tell. Very good. But the treatment will be similar for the two patients or not?
For the male, we need to do an invasive endoluminal, for instance, with coronarography.
But we did for both already. I mean, we did coronary angiography for both already.
Percutaneous coronary intervention for the male.
Okay, that means if there is a stenosis, we can treat the stenosis. But you know, even though it seems to be logical, there are some studies, courage and ischemia studies, which show that the patient with stable coronary artery disease, with severe stenosis, which is not left main stenosis, has the same prognosis if you treat with stent, with angioplasty, like you suggested, or you treat only with drugs. The only thing, the only difference is that with stent and angioplasty, the angina will be treated better, and the patient will be, the life of the patient will be better than with medical treatment. That means I agree with your suggestion, only it's not mandatory to do angioplasty. Usually there is a discussion with the patient and you have to present that the prognosis is the same, only the symptoms can be improved with angioplasty, and you have to decide what to do with his approval. Okay, obviously it is not the case for the female patient because he has no coronary stenosis. But the treatment, the general treatment, preventive treatment, and anti-anginal treatment has to be the same, even though those medications that you mentioned, like beta blocker and calcium blocker, are less effective in microvascular disease, which probably is the explanation for the angina in the female patient. Okay, I had another patient. That means sometimes you cannot decide it on clinical basis which patient has coronary stenosis and which patient has only microvascular disease. That means a defective dilation of microvessels, because the clinical presentation can be the same. You see, in this case, it was very similar presentation, but with such a difference in mechanism. Okay, I had another patient that I presented to your colleague last week. It's a female patient, 66 years old, like the other, but he is different, which has a mitral valve prosthesis, metallic one, which was implanted in 1998 for mitral stenosis. The patient evolved very well, and she is on antithrombotic therapy, anticoagulate therapy because of the valve, with acenocumarol. This is anti-vitamin K drug. And from 1 week, she started to have chest pain during stress or effort, but even during rest. And he was admitted in the ward with a suspicion of unstable angina. What do you think that can be the mechanism of unstable angina in this patient?
What type of valve was it?
Bi-leaflet valve, mechanical one. What was doing?
So maybe a prosthetic valve endocarditis or something like that.
Can be. Yes, we have to review everything. Can be endocarditis with a vegetation and an embolism from this vegetation. I agree. What else? But it was not the case. What else can be?
Thromboembolism?
Thromboembolism from where? It is possible, but give me some more details.
I'm not sure, but like metal valves do like hemolysis, the blood breaks down, and maybe that's the cause.
Exactly, can be on the valve. You know, the patient with antivitamin K cannot be maintained perfect anticoagulated all the time. There are some index of efficiency of the anticoagulation. Usually, if it's more than 65% of time, when the anticoagulation is in range, is good. That means 1/3 of the time the patient can be without proper anticoagulation and can form some small thrombi which can emboline like Akiol. How you call it? Halime? How's the name? Your
Yeah,
name? Halime. Halime told us. Thank you. Very good. Some other causes of unstable angina, the patient in the last week, a patient with a metal prosthesis, 66 years old patient. If you have some ideas. Okay, we have to think about, you know, the prosthesis was put it 22 years ago. Probably it's an old disease. If is any problem with the aortic valve because the patient has an age right now, and maybe if there is a mild aortic stenosis can be more severe in time, and maybe an aortic stenosis can explain this chest pain. Sometimes happen this, but it's not the case. The aortic valve is clear, is normal, no problem.
Anemia, maybe?
Anemia, yes, a patient which takes anticoagulant therapy every day in the last, let's say, at least 22 years can have bleeding and secondary anemia. Yes, you're right, but it was not the case. But everything what you put is okay, and it's good that you think about it. Actually, the patient has a regular unstable plaque which make a very tight stenosis on the LAD, and this was the mechanism of unstable angina and was treated by angioplasty and stent for this stenosis. Okay, that is a little bit, is very classical, even though in a patient with metastenosis is rare to have atherosclerotic disease as well. Usually they are spare of this. Okay, after we put the stent, we have a problem with this patient, because after the stent we have to give some antithrombotic therapy who knows which antithrombotic therapy we have to do. We have to give after the stent. It's somebody that knows this. Okay. Usually, after we put a stent, we have to give dual antiplatelet therapy. That means it's aspirin plus clopidogrel, usually. And this is for a certain period, usually 6 months. This is 3 months or 6 months. But because it was unstable angina, it's usually 1 year for this association. But the problem is that the patient has an anticoagulant therapy as well. And from this reason, for this, because of this, the patient has a risk of bleeding because has triple antithrombotic therapy, anticoagulant plus aspirin plus clopidogrel. And for this reason, usually in this kind of patient, the antiplatelet therapy is ended earlier, 1 or 3 months for one of the components and 6 months for the other one, maybe 1 year. Finally, after 1 year, the patient will receive only anticoagulant therapy for the valve, because on the long term, it is said that can protect for unstable, unstable complication of the plaque as well. Okay, good. Let's speak something about ECG. I'll try to present you the ECG. One moment. Okay. About ECG. You see? ECG? You see. I hope. Who knows? Who tried to tell me something about this ECG? Are you still there or not?
Yes.
Yes.
Yeah, try. It's not simple. It's a little bit complicated, but still, I ask you to try to tell me something about it.
It's a right bundle branch block.
Okay. Sometimes I can tell. It's a little bit complicated. This one. Let me tell you a few things about ECG. I want you to interpret ECG in this manner. The first step, take a general general view of the ECG to have some idea, but after that to try to determine 3 things. 1, the heart rate. Second one, which kind of rhythm you have. And the third one, which is the QRS complex axis. After that, start to examine the ECG and examine first the QRS complex, and after that the repolarization, that means ST and T wave, and finally the P wave. And actually the most important thing in P wave is the relationship of the P wave with the QRS, not necessarily the morphology of the P wave. Okay? And in those cases in which the rhythm is not easy to be established from the beginning, you have to try to determine some, let's say, stage diagnosis. 1, to know if the QRS complex is narrow or large or enlarged, wide. Okay. The second one, if the rhythm is bradycardic or tachycardic. The third one, if the rhythm is regular or irregular. And the fourth thing, if the P wave, if there are some atrial activity, and which is the relationship between the atrial activity and the ventricular activity. These are things which have to be established for knowing the actual rhythm. Sometimes it's difficult. And actually, if you take a look on this ECG, you can see that there are two different QRS complexes. Yes? What you can tell me about the AV rate, the heart rate
Bradycardic.
is bradycardic. How much? Can you calculate?
Around 40?
Yes, let's say it's even less than 40. Okay, for counting, so calculating the heart rate, you have to divide 1,500 to the number of small squares between two consecutive QRS complexes, okay? If it's regular. And this is the most precise. If you want to simplify by big boxes, let's say, you divide by 5, you simplify by 5 and divide it 300 to how many big squares are between two consecutive complexes. And actually, if we apply these, we can see that it's 300 divided by 7. And these mean 40 something indeed. Okay, but the rhythm is regular or irregular? What do you think?
Regular sinus rhythm.
Sinus. But the rhythm is not sinus.
Is it a junctional rhythm?
No, actually, it's like that. It's a little bit complicated. I can tell you the first complex, which is LBBB aspect, is not the right BBB, but LBBB, is it's related with a P wave, which preceded. And the last one is in the same range, is with left bundle branch block, and it's conducted by the P wave. The rest of them are not, the P waves are not going to the ventricles, and this is an escape rhythm from the ventricle with right bundle block aspect. If it's with RBBB aspect, where is coming wherefrom is coming the impulse? From the left ventricle or from the right ventricle? What do you think? What? Tell me again, I didn't understand.
She said the left ventricle.
But why I didn't hear? Yes, left. Yeah, you are right. It's from the left because the right bundle branch block shows that the impulse arrive later to the right ventricle. Indeed, yes. I tell you again, it's a bradycardic rhythm with a block, actually, with a second degree block in which more than high degree block, let's say, more than one P waves are not conducted. And because of the slow rate, there are some idioventricular rhythm originated from the left ventricle to maintain a convenient heart rate. Yes, but actually, if we take out these right band branch block complexes, we see that it's a high, it's a second degree high grade BAV unobserved AV blocks. So sorry, I made from many. Okay, and these important ST changes are secondary to the RBBB respective to the LBBB. A secondary, okay? Let's take a look on this. I let you describe this ECG. It's easier, of course. Can you tell me about this?
I mean, the most obvious is like atrial,
It's a model with what?
atrial fibrillation.
No, actually it's not. Why you tell me about atrial fibrillation? You take a look to, you look to the V5 or tell me, try.
Little,
No, I am open to discuss, but I don't understand exactly. Sometimes I can tell you because a lot of students have this impression that it's atrial fibrillation. If you speak about these small waves which appear in lead one, these are because of the poor contact. That means are if and the same with the V5. And actually, we can see a nice P wave. Usually, we take a look to the lead 2 and V1 to see the P wave. Those are the best for P waves. Here we can see very, very well in lead 2. Wait a minute. Nu mă duc să la curs cu studenții. Vă sun eu. Ah, foarte bine. Păi lăsați așa cum este acum. Perfect. I-a scăzut tensiunea cam mult. I-a scăzut tensiunea, avea 7 tensiune, de asta am scos. Eu așa aș lăsa, dacă tensiunea e bună. Da. Mulțumesc. Da. Mulțumesc. Mulțumesc, să rămână. Excuse me, sorry. Hey, I wait for you.
ST elevation in V1, V2.
Yes, there is. Oh. Yes, there is, but tell me about rhythm. What do you think?
Normal rhythm around 75, 70.
Yes, seems to be a sinus rhythm, indeed. I mean, every P wave is followed by a QRS complex. That means it's conducted, it's okay. But the QRS complex, it's narrow or wide?
Wide.
Wide.
And it looked like bundle branch block. Which kind of?
Left.
right?
Decide, left or right?
Left.
I think right because like on V1 and V2 it's like low S.
Um,
Left.
eliminates a left one. I will tell you. There is a single, only one one lead in which you decide if it's a left or right Van der Blatt block. This is V1, and it's a simple rule. If it's positive in V1, it's a right Van der Blatt block. If it's negative in V1, it's a left Van der Blatt block. Okay? Only for remembering. And this actually has no M shape here, but has here some M shape. It's a left one. Okay?
Okay, thank you.
No problem. That's the place to ask and to get an answer. But still, even though maybe you're right, it's not a proper LBBB because the patient has the complex has very small, a tiny wave here and here and here before all complexes. What do you think that can be this very small wave?
Pacemaker.
Exactly. It's a spike, actually. It's a spike. You see, it's a very small, a tiny wave, like a small line before the starting of the complex. Yes, and actually, this is a pacemaker. Actually, it's the same. I don't know if it's the same patient. Doesn't matter. It's a pacemaker, and this is a specific way of working of the pacemaker. It is called VAT. I don't know if you know anything about pacemakers. Somebody told you or not? Okay, I will tell you a few words. Sorry, at which hour we have to finish for having time to follow the lecture?
12.
12. Okay, good. For pacemakers, there are 3 letters, important letters, which show the type of pacemaker and the mechanism of action of the pacemaker. First letter is the chamber in which it is put the electrode for depolarization. And this case, it's clear in the right ventricle, and this is the usual place because there is a left Van der Blatt block. The second one is in which chamber is put the sensor which sense the native activity and inhibit pacemaker activity when there is a native activity. Yes, and this in this case can be atrium because these have natural P waves, native P waves. Okay, and the third letter show what happened if the device senses a native activity in the chamber in which has the sensor. In this case, let's say atrium, and can be inhibiting or triggering. In this case, probably it's a triggering. Has a sensor in the atrium and sense the natural native P wave, and after that trigger the spike and the ventricular depolarization. That means it is called VAT. Ventricular is discharging, atrium is sensing, and the activity when sense a P wave is to give a spike for ventricular depolarization. VAT in this case. It's a little bit complicated, but it's important to know why not. Let's see what I have more. I have. It's the same patient actually. Okay. What about this patient? You can tell me something. How is the rhythm? Is regular or irregular?
Irregular.
Exactly. It's bradycardic, tachycardic of norm or normal. It's rather normal, let's say, in average. What about the complex? Is narrow or wide?
Narrow.
It's not wide enough, let's say. It's a little bit enlarged, but not. It doesn't reach the limit. Actually, in ECG, you have to learn some duration and the limits for judging if it's normal or abnormal. In this case, for QRS complex, has to be more than 0.12 seconds to be considered that it's enlarged. It's not the case. It's less than that. Even though has an aspect suggesting RBBB. It's not perfect, but suggests this RBBB because has an enlarged S wave in lead 1 and AVL. This is characteristical for RBBB. But doesn't matter. I don't want to stress you too much with this.
There's some deep Q waves.
Here in V5 and 6 now.
And
Yes.
one as well.
One as well.
One
Yes.
AVL.
Yes. Yes, indeed. There is. Probably can be a previous MI because it's big enough. Even though when we judge about Q waves, the most important thing is duration of the Q wave, and this is not long enough. It's important like dimension here, but it's not enlarged. For this reason, I'm not sure. Usually in lateral leads, you can see some Q wave. This is bigger than usual, but you can see sometimes because it's a septal depolarization. And if is any normal Q wave, you can see in those lateral leads. Okay, I don't know, maybe, but I'm not sure. In this patient with some conduction problem, I'm not sure about previous MI in this case. What else? What about the QRS axis?
Normal.
Normal quadrant, yes, agree. What about the rhythm? Which rhythm is this? It's a block, it's an atrial flutter, or what it is? It's unusual, I can tell you. Okay, we see some atrial waves, this kind of atrial wave, with a frequency rate of about 150 per minute. And this is not characteristic for flutter because it's too low for flutter. For fibrillation, not at all, because fibrillation is even quicker than that. But it's not a P wave, a sinus P wave as well. Probably it's an atrial tachycardia with block. That means atrial tachycardia at 150 per minute with high degree blocks. Probably this is the diagnosis. You see, I wanted to show you because sometimes you can read what it's written on on the ECG. The device made his own interpretation, but not all the time is good. For instance, it's written about atrial fibrillation, which is not the case. It's not atrial fibrillation at all. Written about right axis deviation, 111 to 169, which is not the case. You see, you don't have to rely entirely on the machine. Actually, it is written on everyone, has to be reviewed. And I'm glad that you didn't fell in the trap, and you told me with your own interpretation what the results is. Okay, good. I finished with ECG. I finished with everything. If you want to ask me something, please ask me.
I
Otherwise,
have a question.
yes, please.
Is this a 4th-degree AV block then?
No. We can, let me tell you something about AV blocks. First degree AV block means every P wave is conducted to the ventricle, but with a delay. The second degree AV block is some of the P waves are not conducted to the ventricles, and the third degree, no P wave is conducted to the ventricle. But in this case, it's completely different, because actually these cannot be called P waves. They are atrial activity, probably atrial tachycardia, with blockage. They are not conducted to the ventricle one-to-one. Otherwise, the rate will be 150. And they are conducted with blockage, an AV node blockage, which is a normal blockage of the conduction for protecting ventricle from high frequency. Okay, it's not a third degree.
I asked it because of the 4th lead, so the difference in duration of the P waves, it's equal.
Difference in duration
Between two P waves is always equal, that's why I've asked. And it's different.
It's a regular atrial rhythm, but it's not sinusoid. It's not sinus, and we cannot call P waves. You can wonder if it's like that. If it's block, but it cannot. It's no. There is no other explanation to be a complete block and ventricular rhythm, but it has to be regular. This is not the case here. It's irregular. No, cannot be an explanation like that.
Okay, thank you.
Yeah, okay. Ask me something else if you want. From lectures, from what we talked today, from everything. No problem. Okay.
In the morning, I had an internet issue and I entered 10 minutes late and I missed the attendance.
No problem. No problem.
Okay, thank you.
Okay. Okay. Then I say you hello, bye-bye, and we'll meet tomorrow. Good?
Yes, thank you so much.
Thank you.
Thank
Doc.
you.
Bye.
Thank you.
Thank you. Bye bye.